Welcome to the Global Diabetes Insight, the go-to podcast for navigating the world of diabetes. I am Tino, a certified diabetes educator and a global advocate for non-communicable diseases.
And I'm Konna, a global advocate and a medical doctor. Together, we're your hosts, dedicated to raising awareness, fostering open discussions, and creating a safe space for everyone affected by diabetes.
Join us as we dive into important conversations with individuals living with diabetes, caregivers, healthcare professionals, and researchers. Our goal is not only to guide you through effective diabetes management, but also to inspire advocacy for proper healthcare access.
So get ready for a journey of insights, ideas, and diverse perspectives. Let's amplify our collective voice and create positive change. Get involved, get engaged, and join us in creating the change we need. So welcome everybody to Global Diabetes Insights. Hello everyone, welcome to the Global Diabetes Insights. Together we have with us Dr. Jamie Wood. Thank you very much for being here. Would you like to introduce yourself?
Sure. Thanks for having me. I've been looking forward to this for a few months now. I am a pediatric endocrinologist in Cleveland, Ohio, in the United States. I have been taking care of youth with diabetes for my whole career. So it's been about 20 years now. I'm the medical director of our pediatric diabetes program here at our hospital called Rainbow Babies and Children's. I'm also the director of our local diabetes camp, which has been operating since the 1920s, taking care of families and youth with diabetes. But one of my biggest roles is that I am the Secretary General of ISPAD, which is the International Society for Pediatric and Adolescent Diabetes, which is a volunteer role, but one of the favorite parts of my weeks. And I'm the mom of 2 teenagers. I love to exercise and be outside in nature and hanging out with my kids and dogs.
Thank you. I think the most important role is being a mom. The most difficult one. I'm not a mom, but I assume. So we're going to break down your different roles. And first of all, I would like you to share with us what it's like to be involved in pediatric endocrinology and especially in the pediatric diabetes field. How do you feel about that? How do you experience the connection, taking care, not only medically, I assume you take care holistically of the patient and their families. So how that has been?
I am clearly biased, but I think pediatric endocrinology is one of the most exciting fields and subspecialties to be involved with. I knew I wanted to be a pediatrician ever since I was a little girl. My parents said I announced it in the 4th grade. I've always loved children. In my undergraduate studies, my major was childhood development. And I thought I was going to be a pediatrician. I thought I wanted to be a primary care general pediatrician until I was exposed to a single young girl who was diagnosed with type 1 diabetes around the age of 9 in severe diabetic ketoacidosis and nearly died, a dreaded complication of cerebral edema. And I met her in my last year of medical school and met her parents, worked with a pediatric endocrinologist in Maine named Dr. Jerry Olshan, who's quite a legend. He introduced me to the field and let me help take care of this young girl, and she recovered completely. I helped her family learn how to take care of herself over, several days in the hospital, and really just fell in love with, like, as you said, the holistic care of a child and her parents, and that caregivers also need lots of support and education. And when I went to write my residency, I was able to do a rotation at our local diabetes camp. And so this was 23 years ago. It's the camp that I still work at. I went there for a week as a resident to volunteer. I got sort of live side by side with youth with type 1 for a whole week, swimming and canoeing, archery, and doing arts and crafts. An immense respect for the kids and what they live with day in and day out with such courage and spirit, and just decided at that point that this is what I wanted to do with my career. And what's nice about it is I see families every few months. I develop really close relationships with my patients and their parents, and I feel like I can make a big difference so that I can help these kids live their lives to the fullest and not let diabetes dictate it, that they dictate their own life and diabetes has to fit around it. It's an honor. It's a lot of fun, hard work. Sometimes there's hard, long days, but I absolutely love it.
I'm biased too, but I totally agree with what you said. And also, I think that you can feel the reward, the impact you make, how you support, how you guide people who are getting older, who are discovering themselves, and also who are getting more mature while having the disease. You said that you help or guide people to not let diabetes dictate their lives, which is really challenging because when diabetes comes to a family, everything changes, everything is scary, everything is new, everything is different. Somehow the kid has two identities, their proper one and their diabetic one, and they have to balance all of it. How do you manage as a healthcare professional all this new information? How do you manage to deal with it and how to train the kid and their families?
That's a huge question. I think I would boil it down to when a family is first diagnosed, as you said, it's incredibly overwhelming. And you really have to help families break it down into learning things step by step, giving themselves the time to adjust, really to grieve. It's a huge adjustment and it's a huge change for the kid as well as for the family and for siblings. And they really need the time to, and they need to be sort of given permission to be angry and sad, all of those things, and just reassure them that we're going to get them there. And that at first it's incredibly overwhelming and scary, but with time, they're going to gain confidence. In a way, it will be their new normal. I just reassure them from the beginning that with time, I'm dedicated to help them and my team. I have a huge team that helps me take care of these families. They can do anything they want to do with diabetes. If diabetes has stopped them from doing something that they want to do, then I have failed and my team has failed. Like if they want to play sports, if they want to a school trip to Washington, D.C., if they want to, whatever they want to do career-wise, or just I want to help them manage their diabetes so they can do it. And so I reassure them from the beginning that that's my goal and that is what we're capable of doing now with modern management, with the different types of management we have. And I'm a big believer in that families and the people living with diabetes should have a big say in how they manage their diabetes. Different management styles will fit into different types of lives and lifestyles, whether it's using a continuous glucose monitor, or maybe it's a pump, or maybe it's inhaled insulin, or maybe it's, the different a combination. And sometimes maybe a pump is better. I had a patient yesterday who's like so burned out and just was like, came in and just really struggling and tired. And she said, Dr. Wood, can I just take a break from my pump and go back to shots for a couple of weeks? Like my skin's tired. I just don't want anything on my body. So you have to have that flexibility. The other big message that I talk a lot about is not comparing yourself to others living with diabetes. Diabetes is so individual. What works for you may not work for somebody else, and vice versa. Each youth and each family sort of has a goal of what they want. Maybe they have a goal for an A1C. Maybe they have a goal for time in range. Maybe they have a goal of, I just want fewer low blood sugars, or I want to get my A1C down under 10, or whatever it is. You want to make sure that you want to have a good understanding as a provider of where does that family want to be and what matters the most to them. For some people, fear of lows is understandably a priority. Maybe they want to work on just working on the lows, or maybe I want to be able to go play soccer with my friends without having a low. So figuring out what's important to them, what will make living with diabetes easier for them, and working on those different parts and pieces. I guess my other big thing is, and this will be my last, is I talk a lot about eliminating the shame and the blame and the guilt that comes with living with diabetes. And particularly for the teenagers I work with, I had clinic yesterday and I was there until like 6:00 at night. I had a whole bunch of teenagers that I was caring for, and just making them understand that I'm their cheerleader, I'm their coach. Hopefully they see their healthcare provider and their team as a helpful resource and not as a judge or somebody to make them feel badly about their diabetes, because diabetes is hard enough. You don't need people judging you and making you feel badly. So I think going into providing, working with families with those sort of key priorities helps a lot.
I was so touched by the comparison because I keep saying that there is toxicity going on in our diabetes representation through social media, where everybody shows how perfect their diabetes is. And that could be really stressful for people who, for example, struggling with their fear of lows, and they see some 100% timing range for I don't know how many days, or even for people who do not have access to the newest technology and they
Right.
want to. So yeah, the comparison is so essential to avoid, but that's just mentally.
It's the double-edged sword of social media. In some ways, social media is amazing in that you can connect to the diabetes community so easily now.
Yeah.
And you can get a lot of support through social media. But I also feel like, I have parents coming in. I had a parent just yesterday, I mean, every single day, a parent coming in who has a 2-year-old with diabetes, just diagnosed a few months ago. And she's like, but I saw this on Facebook, or I saw that on Instagram. And why don't we have 90% time in range? Or like, why don't, and I'm like, it can be hard. And unfortunately, people can be unkind sometimes on social media too.
Yeah, that's something that I keep saying because we don't represent ourselves correctly. That's my opinion. If we just show how great we are, because that is a matter of access to healthcare, access to the products we need, and also psychological effects, eating disorders, everything needs to be in balance in order to have that perfect timing range. If you just show it without explaining what you did for that, it's like putting pressure to other people living with type 1 diabetes. I wanted to ask you, diabetes is a medical condition, is an unstable factor in a kid's life, and the kid often gets stressed or sick. What piece of advice, or how do you manage when a patient of yours, a diabetic patient of yours, becomes sick or has some ill days, which I assume is very often? How do you manage two medical conditions at the same time who interact with each other in a not very safe way?
Sick days are really challenging. And I also, it's not just sick days, but it's stress days, I call them too. Maybe you're not ill, but your body's stressed. And your diabetes tends to misbehave on those days. And so I think a lot of education, and you have to repeat the education frequently to teach youth and their parents how to handle those days. I think the first thing is helping them understand why it happened. Why is diabetes harder to manage when you're sick or stressed? And that's because your body makes hormones, the adrenaline and cortisol and all of those hormones when you're sick or stressed. And all of those hormones antagonize insulin. They make insulin, the insulin you're making or giving, less effective. So oftentimes people will run into high sugars and maybe even sugars high enough to make ketones when they're sick. And so the first is just understanding what's going on. The second is, the most important thing is, even when you're sick and you're not eating well, don't never stop your insulin. You may need to adjust your insulin, but don't stop it. And the third is just really frequent monitoring. So you want to be checking your blood sugars more frequently, either by finger stick if that's what you have, or if you have access to a continuous glucose monitor, using one of those is helpful. And also checking for urine ketones if you have access to that. And that will give you an idea of what you need to do. And most people when they're sick need more insulin. And so we teach our families, based on what the blood sugar is doing and what the ketones are doing, how much to increase their insulin. We call that booster doses, so that say their blood sugar is 300, and when they're not sick, they would give 5 units of insulin. But say they're sick and their blood sugar is 300, but they have ketones in their urine, I would have them give maybe 7 units for that same blood sugar, depending. And so teaching them how to adjust, making sure you're staying hydrated, and then also trying to figure out why you're stressed or why you're sick and treating that. Treating the underlying stress helps a lot. So if you have fever, taking a medicine to reduce your fever. If you have pain, taking medicine to reduce your pain. All of those will help reduce the stress and lower the blood sugars. When I was early in my career, I've learned so much from my patients. And at first, I didn't really believe that emotional stress could have as much impact on the blood sugars as they do until I went to diabetes camp. I tell this story all the time to parents, because parents are like, his blood sugar is 350. He must have not given insulin, for lunch or something. And the kid is like, no, I did. I just had a really bad day at school. And I was really stressed out about a math test. And I got a fight with my friend. I gave insulin for lunch, but yes, I'm 350. But and the parents are like, no, you didn't give insulin. And I've seen it happen where I was at diabetes camp and I had two teenage girls. They had a very serious disagreement, very emotional. They were very upset. I was watching both of their CGM. They were double arrows up, spiking into the 300s, both of them, because their emotion, they were so upset. Anyway, so dealing with emotions, making sure you're getting support, you're learning, making sure that your mental health is getting also taken care of, because it's a big impact too.
I experienced that emotional stress in my finals at medical school. It was
Oh
like
my God, yeah.
my body didn't recognize insulin at all. My body refused the presence of insulin and my pump. You said that about emotional stress, which is really present at the stage of adulthood, which still you have your patients also at that stage, and maybe they get diagnosed at that age or get through that phase while being diabetic for ages. How is the transition and how do you manage diabetes? Because in adulthood, year to year, month to month may vary because of hormones, body changes, the calculations, the indexes are just so, the variables are so easily changing. How do you manage such a period with the emotional stress and the physical changes that a teenager is going through?
I think one of the biggest challenges of living with diabetes is that your body's always changing, and so is your diabetes. And so you have to think about each of those phases. Puberty is a very difficult phase to navigate with diabetes. It's also a really fun time to work with teenagers. I love working with teenagers. There's challenges, but they're also just a lot of fun. But their bodies are changing and they're crazy. Their hormones are everywhere. They're growing. Growth hormone makes insulin work less well. Puberty hormones make insulin work less well. And then you have all of the variables of being a teenager, the emotions that come with being a teenager, and the variable activities and staying out with friends and wanting to do sleepovers for the first time, things like that. And so really, it's just really close communication and teaching families that we need to frequently adjust things. We need to frequently look at numbers and make adjustments because things are always changing. Puberty dies down, then teenagers and young adults are starting to think about maybe going to university or moving out and getting a job or just having independence, having to navigate insurance or navigate jobs, things like that. And so my big thing is continuity of your healthcare team. If I have a young adult that's going to college, and I just had a young adult yesterday who just moved out and she got a job and she's living on her own for the first time, I'm still caring for her, even though she's 20 and she lives alone in an apartment and has a job, because I want to take care of her through that transition until she feels settled. And then maybe we can talk about finding her an adult doctor who can take over her diabetes management. It's not a good time to change your healthcare team when you're in a transition. So that's the biggest thing, I think. And then you have to slowly transfer the diabetes knowledge from the parent to a shared decision model where the parent and the teenager work together, but the parent is still very involved and knows what's going on. So if things slip up, they know and they can help more, to this gradual independence. Some parents continue to manage the diabetes, have a harder time letting go of that and letting the teenager take over more. And when that abruptly ends, it doesn't go well. It needs to be more gradual. The teenager needs to practice when they're still within the safety net of their family. And then the other thing is, even if young adults become fully independent with their diabetes and they're on their own, it's really important that they understand that even though they're independent, that they always still have their support system. Their support system may be different. It may be friends. It may still be their parents. It may be their significant other. But the expectation that a person with diabetes can do it all by themselves all the time is just an unreasonable expectation. And making sure, as I said before, that at each of those time points, you're doing a check on mental health, in that you're asking often screening for anxiety and depression, diabetes, burnout, so that you can get somebody's support early.
Yeah, when I was an adult, I was a rebellion against my diabetes and I just couldn't control it. I didn't realize that I was rebelling against the disease. Back then, it was also more difficult to have a full control of what I was doing because there were no CGMs. There were just 4 times a day to see how was my blood sugar. And now it's good and bad that adolescents cannot easily escape of the monitoring. We can see what they're doing and that can be pressures for them, but we can help them in a way.
Yeah.
And also, they cannot lie because I could so easily lie about what I was doing because there were no clues at all.
Yeah.
And everybody
Yeah.
had a gap about what happened, and my blood sugar just spiked so much. And I was like, I did nothing. I was
Well,
guilty.
no, and it's good and bad, right? It's good because then we know exactly what's happening and we know how we can help, right? But it's like if they're like, oh yeah, I never miss any boluses, never.
Yeah, that was
And then
me.
we look at their pump download. I'm like, the last time you bolus for food was last week. Like, so it's good and bad, but it's that concept of if this saying will translate, but we call it a big brother. Somebody's watching you.
Yeah.
And a lot of teenagers, especially, and some young adults, really don't like that their parents are watching their CGMs or that, I can log in and see what everything they've been doing. We actually talk about that a lot.
I think I wouldn't like it either. I was in my pediatrics rotation in medical school, and one mother asked me how my parents monitor me when I was younger. And I was like, they didn't. I just go to school. They knew that I was okay when I just go back from school at home. And they're like, we're losing the signal for 5 minutes. And we're like, what's going on? Is our child okay? And I don't know how we can balance this because I don't think that's quite healthy to have that stress that you have to watch your child, then you knows that he or she is being watched. I don't know, CGMs have just become a part of our lives, but I don't think we have found the right balance yet.
One message that I talk about with parents when their child is first diagnosed is that I don't view children with diabetes as fragile. I view them as strong, otherwise healthy. The only unhealthy part of your body is your pancreas doesn't work.
A part of your pancreas.
It is only part of your pancreas. It is a really small part of your pancreas.
Yeah.
Everything else is really healthy and strong, and that I don't view children with diabetes as sick. I don't even call it a disease. It's a medical condition. I just think that messaging is really important, but yet we give the opposite message when we say we have to watch their blood sugars every 5 minutes, 24/7. It gives, I think, parents and teachers, their kid is very fragile, which I agree is the intensity of management and monitoring has swung, which is great in a lot of ways, but it comes with, I think, a lot of stress of all of the data and that you have to watch all of the time. But I agree, it's hard.
Yeah, I didn't experience, but I don't know how that can have an impact on the young adult. I would like now to take you through your research work. I always admire medical professionals who cover every part of medicine, clinical, research, holistic approach. I know that you're focused on the clinical outcomes. I would like you to share with us what you have learned through all this process of the research work and how that has been through the years for you. And also what made you decide that you will also like to be involved in research as a medical professional?
Maybe I'll start with that first. I think when I went into residency, I thought I would be a full-time clinician. I thought I would be taking care of patients. And then when you do a fellowship, research is a requirement of the fellowship. I had to do research in order to become a pediatric endocrinologist. And I loved it. I did do a couple years of basic science research in a lab, and I was a disaster. I do not belong in a basic science lab with like pipette and things like that. Like that didn't go well, but I really loved working with people with diabetes in the research setting, because participating in research for people with diabetes, I think, can be really empowering. And sometimes you feel like being part of the progress and being part of the solution of how to make living with diabetes easier, even if it can't directly help you now at this moment. I think it feels really good for you kids, teenagers, adults, and their parents to participate in something that's bigger than themselves so that they can contribute and just say, I helped with that. And I find working with, people with diabetes and their families in research studies really fun, because we're often exploring new horizons. Like I'm doing an inhaled insulin trial right now in pediatrics. Inhaled insulin is approved in the United States for adults with diabetes, but not for children. And so we're doing the study to get that approved. I get to hang out with these kids and their families at the research visit. I get to talk to them all the time. I really enjoy it, to be part of the process that it brings more options to people living with diabetes is really gratifying. I've also done a lot of clinical trials to get medicines for type 2 diabetes approved. I take care of all types of diabetes. Unfortunately, we're seeing more type 2 in teenagers than we ever have. A lot of the medicines that we have to give adults with type 2 have not been studied in teenagers. I've done several of those trials, and now we have several new medications approved for teenagers with type 2. So that's, again, I love helping them have more options. And then the outcomes research is fun because that was earlier in my research career. I'm getting back into it a little bit, but sort of early on, I did a lot of registry studies or consortium-based studies and they were US based. So we don't have a national registry of people with diabetes where we can follow everybody, but we do have some large, what we call consortiums, where different diabetes centers across the country share data anonymously, de-identified data, so that I can compare how are my patients with diabetes at my center doing compared to people with diabetes around the country. And then we can compare and contrast sort of what we call best practices and learn together what are the important management differences that predict outcomes that we want or people with diabetes want. So part one was the T1D exchange, which you may have heard is US based. And then now our center is joining the T1D exchange QI collaborative, which is a similar idea. Multiple centers across the country sharing their quality data and then working together to figure out what the best practices are. And that's really helped. I've learned a lot from that, and it's helped the care that I give my patients.
Yeah, Dino talked with Dr. Chantal Mathieu about the research, and she was like, I'm focused on being able to answer why I'm doing this project. Why am I doing this research? I find this answer also in your words, like research is a process, the outcome is a product, and the diabetic and the patient is the consumer. I think you have clear why you're doing this in order to know the purpose of it, because it's a long process or even boring. But yeah, at the end of the day, if you know why, how people are going to have a profit from it, that gives you a purpose. And I think that gives also energy to keep going, because I think clinical medicine has more interest because you interact with people.
Yeah. And I think it's also what I am really happy about, and something that ISPAD feels very strongly about. And that's how I met Dino, is the patient voice and the voice of the person with diabetes. And I think making sure that we include the voice of the person with diabetes in that process is super important. What are the priorities? For example, for ISPAD, we have guidelines that we publish every few years. We have 25 chapters of guidelines on different topics, all about pediatric diabetes. But one of our criteria is that a person with diabetes has to be one of the authors on the chapter or had reviewed the chapter, because we always want that voice. When we're planning our annual scientific meeting, there's always a person with diabetes on the planning committee. Are the sessions that we're planning for our annual conference relevant? Are we picking the right topic? Having that feedback. And then the last couple of years, ISPAD leadership, just this first year, we now have patient advocate on our advisory council, because we want to make sure that the work that we're doing for ISPAD resonates with person with diabetes. That is even more so important with the process of research.
That's totally true. I know that you're involved in your hospital with many projects, but share with us the college prep event. How could the diabetes online community contribute, be involved with this project?
We actually haven't had that event since COVID. We need to sort of regroup, bringing together young adults who are in the process of transitioning to college. But it's not just college, it's college and beyond. Young adults maybe transitioning to the workforce, just becoming independent. And what I've done is I'll pick usually a weekend day, a Saturday or a Sunday, and bring the young adults with their family to the diabetes center. We do a lot of education. One thing that often happens is that a lot of the diabetes education has been targeted towards the parents, and the kid has been sort of listening to it over the years, but they've rarely had sessions where they receive the education. So we spend a good part of the day just talking about diabetes management, about sick days, about alcohol, about drugs, about driving cars, about insurance, having lectures on all the different topics that they need to hear about. And then we would do breakout sessions where the teenagers would just meet together just with teenagers, and we usually would have a mental health professional helping moderate that discussion, and then also a session for just the parents, because they're going through their own fears and their own anxieties about their child leaving to go to school or to move out. Just having small groups, there's just lots of support. There's a lot of resources out there, so we would share resources. We collaborate a lot right now with our local diabetes camp Homey Dakota, and our local branch of the JDRF. And so we also sort of co-sponsor events with both of those two groups to support the transitioning young adult and have sort of college prep type events.
That's a great project. Peer support is so important in every group, as long as it doesn't disconnect you from the real world, because sometimes when you overconnect with diabetics, you forget how it's like to live in a world where other people exist. You've mentioned several times about the diabetes camp. I think you've mentioned in one of the sessions you had that diabetes camp is the best place to be for you. Can you talk about that?
My first experience at diabetes camp was in 2001 when I was a first-year resident. I've only missed, I think, 2 summers of diabetes camp in those years. The 2 summers I had my children and had a newborn at home. I just love diabetes camp. I love it because, for a very selfish reason, love it because I learn so much when I'm there. I learn how to be a better doctor when I'm there, because I learn what's on the minds of youth and teenagers and young adults living with diabetes and what are their struggles. And I don't think anyone has any idea what it's like to live with diabetes. And an activity camp is like as real as it gets, right? Exercising and playing all day. We're running around. We're eating regular camp food. We're having s'mores with chocolate and marshmallows, eating hot dogs on campfire, and we're sleeping out in hammocks at night, and we're canoeing and hiking and fishing and swimming. And it gives me a lot of respect and understanding about what it's like to live with type 1, because I don't have type 1. I have 2 nephews that do, but it teaches me a lot. But for them, it's just such a joy to watch them be in an environment where everyone else has diabetes. Everyone is checking their sugar together. Everyone's doing insulin together. Everyone has lows, everyone has highs. It just is very normalizing for them. And they just learn that even when they go back to their day-to-day lives, that they're not alone. There's always camp. These kids make friendships and they stay in contact throughout the year. And then they have just something to look forward to every summer where they can go. They described as their happiest place. They feel they belong there. They're not different. A lot of the emotions around diabetes, from what youth share with me, is that they feel different. And it's really hard for a young person to feel different, particularly in middle school and high school. Like, it's hard. So that's why camp is a special place. And they get to learn a lot too. I mean, they learn how to manage their diabetes around sports, or if they want to have a s'more, how can they handle different types of foods and treats and things like that. And they gain a lot of independence. And so if they come to camp, we'll ask them, what's one thing you want to be able to do this week? Some kids will say, I want to put in my pump by myself. I've never done that. I want to do it by myself. Or, a younger kid who may not be doing their own shots yet. We take kids as young as 6, especially if they're newly diagnosed. They may say, I want to do my own shots. We'll help them do that. So that's fun.
I found myself in your words. I just went to a diabetes adult camp this summer, and it was the first time in my entire life that I didn't feel different, but I wasn't ashamed to scan my sensor. Alarms were going on and off, and nobody cared. Like, yeah, someone is having a high, someone a low. That sentiment of total freedom and a sense of belonging is so essential. Now, I would like you to explain to us one phenomenon that you covered in your recent journal. I will read it. Honeymoon as one of the results of waning and waxing of the autoimmune process in type 1 diabetes. Could you break down this sentence?
Sure. First of all, the concept of honeymoon, or that term honeymoon, I really dislike. I don't like it at all. I've been on a honeymoon before. I went on a honeymoon with my husband, and it was wonderful.
No stress at all.
Right? why do we call a very hard transitional time period in someone with diabetes life a honeymoon? Because it's not like any honeymoon that I've ever heard about. Anyway, so first of all, let's just start out by saying I think it's a really bad name. So what it refers to, a highly variable period of time after someone's initially diagnosed with type 1, they start making more insulin again. They have preserved beta cells that are still working. What the explanation means is there's different explanations for it. One thing is that when you're becoming symptomatic with type 1 diabetes and your blood sugars are becoming very high, those high glucose levels are toxic to the beta cell. So even if the beta cell is still there, is still working, they get sick from the high blood sugars, just like the rest of them. And they don't make insulin as well. And that contributes to additional high blood sugars and more symptoms in getting diagnosed. When you make the diagnosis and you start somebody on insulin and the blood sugars start coming down, those remaining beta cells recover. They start making insulin better. Usually within a week, sometimes 2 of diagnosis, blood sugars start coming down, insulin requirements start coming down. Blood sugars may become more stable, less variable, fewer highs, fewer lows. And that period of relative stability and lower insulin requirements is called honeymoon. And what the sentence about the waxing and waning of the autoimmune process is that there's also theories that just the intensity of the autoimmune process varies. You may have a quieter time where there's not as much beta cell destruction and then more activity later on. Like I said in the beginning, the honeymoon period is variable. Some people don't really have a honeymoon. For example, toddlers very young patients who are diagnosed in severe ketoacidosis often don't have, whereas because probably someone who is diagnosed under the age of 2 with type 1 diabetes has a very intense autoimmune process and very rapid immune destruction of the beta cells. There's just less beta cells and there's not as many beta cells to recover. And then it's variable in length, variable in the degree, but then it's also highly variable in how long. We usually say average of a year. I've had somebody who was in a honeymoon for years. It's variable, and that's hard too, because parents always ask, well, when's the honeymoon going to end? I don't know. But what is nice sometimes about a honeymoon is that after the stress of diagnosis, within a couple of weeks, when the blood sugars sort of stabilize and you need less insulin, that's a time period where the families slow down, they can start learning about pumps, or they can start learning about other things, and they gain confidence in their management. But overall, it's a bad term. I don't like it. And coming out of honeymoon is also a really difficult transition. A couple of patients that have had a very significant honeymoon and actually had to stop insulin for a time period because they were making so much of their own insulin. And then for that honeymoon to end and have to start insulin for a second time, that's really hard. It's a hard adjustment. They feel like their diabetes came back. I mean, it never went away, but they have to adjust to it a second time.
It's like getting to have diabetes in 2 stages, the diagnosis and the actual disease.
Yeah, well, when we talk about 3 stages of diabetes already, and then there's stage 4 and 5, right? There's lots of research looking at how can we prolong that honeymoon. And what we mean by that, rather than say prolong honeymoon, we should say, how can we prolong the time that the beta cells are functioning? And how can we preserve that beta cell function?
The pre-honeymoon.
Yeah.
Yeah.
It's an important research topic to figure out how we can prolong that time period.
Yeah, I know you have been serving ISPAD as a general secretary. I know ISPAD is a great community with so many projects going on and so many healthcare professionals involved and patients involved as well. How that has been? What have you learned from this?
I've been involved in ISPAD since...
I've seen you smiling every time I mention ISPAD. I can already say.
Yeah, I've been involved in ISPAD since 2009. My first ISPAD conference was in Ljubljana. And then I became involved in the advisory council in, I think it was 2014, around there. And so I was on advisory for a few years. And then I became the ISPAD's communications director and directed the social media and the website. Communications director is part of the executive, but then I've been Secretary General. This will be my 4th year as Secretary General. I've done 2 terms. So I sit on the executive, and first it's about friends and networking. I have met the kindest, the most passionate people, and our mission is very simple. It's to improve the lives of children, adolescents, and young adults with diabetes. Our commitment is to be the voice of and the resource about pediatric diabetes globally. What I love is that all of our resources are free, and you don't need to be an ISPAD member to get the resources. We feel very strongly that if there is a healthcare provider in the developing world, for example, who doesn't have a diabetes center, who may not see a lot of diabetes in kids, that they can go to our website and they can download 25 chapters of guidelines for free. There's translated education materials in different languages, and all of those resources, we work very hard to make them available to the world. We would love people to become ISPAD members. It's a great society, but we don't want that to limit somebody able to get their hands on a resource so that a child can be helped. And I just have had so much fun traveling to different parts of the world and working with colleagues from around the world. From the United States, I have access to resources that many countries don't have to care for people with diabetes. We have just awful disparities in the United States too, though, based on insurance differences and other things. So believe me, we have struggles too, but I also feel very grateful that my patients have the resources they have. I'm very committed to working with patient advocates and providers from low and middle income countries to bring access to their communities. I gave a talk at ISPAD a couple of years. We talk about access to pumps and sensors, but in many parts of the world, it's insulin. Just getting insulin so that children with diabetes, don't die from diabetes. And so we work with Life for a Child, CDIC, both two wonderful organizations that help low and middle income countries get them access to insulin and to strips. Our next talk, we're planning a symposium at the next diabetes meeting about diabetes technology and the developing world. But we can't forget that many parts of the world still don't have access to insulin. It's fun, it's gratifying, it's hard work, but it is one of my most favorite roles. I wouldn't have met Tino.
Tina is a great voice for all the diabetes community. I think that podcast session was great. It's a piece of inspiration and motivation for every people who is related to diabetes. And thank you so much for dedicating some of your time to us. I would like you to give some piece of advice to people living with diabetes or healthcare professionals, family. First thing that comes to your mind, or things that as a take-home messages for our audience.
I would say get involved. As I said before, the voice of the person with diabetes is very important. To advocate for people with diabetes, we need everybody to speak up so that the rest of the world understands the impact that diabetes has. Both type 1 and type 2 are increasing. The projections of the number of people who will be living with diabetes in 15, 30 years is staggering. We have a lot of work to understand diabetes, to hopefully eventually cure diabetes. I think we have a mental health crisis in young people, even without diabetes, but people with diabetes really struggle or at increased risk. So getting involved in advocacy and education, the more that people with diabetes speak about their diabetes and advocate for themselves and others, the better the world will be for people with diabetes. Keep advocating, keep educating, and keep working together.
I want to thank you very much on behalf of me and Tino, and also of our audience. I'm sure that everybody who's going to listen to this podcast is going to benefit. You have experience, but you also have the knowledge. You're not diabetic, but I'm sure you're close to understanding what it really means. Thank you very much for your time and for being here in our podcast. A real honor.
You're very welcome. It was a lot of fun. I love talking about diabetes and diabetes camp and ISPAD. So lots of fun for me too. And thank you very much for having me. And hopefully one day I'll meet you in person.
Yeah.